and with the new practice for me, very much established practice for everyone else, but let's begin. So, just a show of hands, how many of you guys know what vertebral compression fractures are? All right, so about half the room or so. Well, it's basically a spine fracture, and we're going to get into a lot of the nitty-gritty and details here. I don't have any relevant financial interest to disclose. What is a vertebral? Well, it's basically a spinal segment, and the ones that we're focusing more on today are the thoracic in purple and the lumbar in yellow. There's 33 segments in the human spine. A lot of times we forget about the coccyx and the sacrum as being part of that, and then in the neck, and potentially any of these regions can fracture, and I've actually treated fractures in all of them, except for the cervical spine. I have not yet to do one. Now, another way of splitting this up is the 3-column module. So if we imagine the belly is here, and the part of the spine that we can palpate just through the skin is back in here. So we're looking at this pretty much anterior here, posterior on the other side. So the anterior column in yellow here is what's referred to when it fractures as a compression fracture or vertebral compression fracture. Once it also migrates into the green area, which is the middle column, we get a quote-unquote burst fracture. And if we have all 3 columns at fracture, that's bad news, and that's something called a chance fracture. And that's typically something that we will be getting on the phone with a neurosurgeon and having them get seen at that point almost immediately. So other considerations that we really need to figure out is this posterior wall here, because the posterior wall right next to that is the spinal cord. So if there's any sort of fragments or retropulsion that exists, then that could potentially be a problem neurologically. So we need to know that. And once we get into discussing the procedure a little bit more, this pedicle, which it's hard to read out here, that's very important to make sure that that's intact, because that's where we're basically putting the device through to fix the fracture. So, how do these occur? How do we actually get vertebral compression fractures? Well, like anything else, whether we're talking about the vertebrae or we're talking about the hip or anything else that breaks, there's usually a force that has to overcome different forces present, right? So if something is stronger than something else that's being supported, that something else will be breaking. So over time though, you will see that there's some vertebral collapse. This usually does not happen in one felt swoop unless there's something of a high trauma like a motor vehicle accident that takes place. So they usually have these little micro fractures that you can sort of see here pictured that eventually will be the straw that breaks the camel's back to create the pain and the subsequent macro fracture in there. So the results, as one would imagine, the spine becomes deformed. You can see it a little bit in this picture that this is not the natural curve of the spine. And of course, as I mentioned before, there could be neurological damage, pain, and with all that, decreased function. The most common level that we see fractured is T12, and that's followed by L1, and then a plethora of lower to middle thoracic spine segments follow. So, I never partook in this product here, I swear. But Joe Camel, I think, was very big, if I recall, in the 90s. This was a major ad campaign for smoking. And unlike alcohol, I didn't know this until recently, if you notice any sort of alcohol commercials, nobody's actually ever drinking the product. Think about that for a minute, right? Have you ever seen an ad where anyone's actually drinking Bud Light or anything like that? Well, with smoking, that wasn't an issue, obviously, as he's smoking. Now, this is one of my favorite pictures of all time when we're talking about vertebral compression fractures, because it says a lot, and I'll explain why. So, Joe Camel here, smoking a cigarette. He looks pretty buff from what I could tell, right? Might be on steroids, I don't know. And he's in the hot tub. So I'm going to explain all that and why that's significant in a second. So we always talk about the straw that breaks the camel's back. That's sort of the theme within pain medicine, especially when we're talking about fractures. So as I mentioned before, you have all these different little micro fractures that can occur for various reasons, but then there's that one straw that breaks the camel's back that makes it a quote-unquote vertebral compression fracture that'll bring the patient into the hospital or the office to get checked out. So in here, that straw could be a fall, it could be lifting, it could be physical activity, sexual activity. A lot of times patients won't admit it, but that's what happens. Changing positions, and then just sporadic. They might be sleeping and they just turn a slight way, and that could create it. The biggest thing that we see is osteoporosis. So probably, I don't have an exact number on this, but it's probably 95 to 99% of patients that develop vertebral compression fractures either are diagnosed or have not yet been diagnosed with osteoporosis. Now, I don't know if he has osteoporosis at this point, but he's certainly smoking, which increases risk, and he might be on steroids as well. And this hot tub analogy, I'd like to say that maybe he's in the hot tub alone, from what I can tell, because maybe he has back spasms from a motor vehicle accident. So I'm trying to give you a visual to remember some of these things by here. I'm assuming Joe Camel is male, so he's probably not going through postmenopause, so that's not part of this. But when you are in postmenopause syndrome, there's decreased estrogen, which estrogen is very important with the maintenance of the bone structure. And then, of course, with spinal tumors, whether it's a primary or a metastatic tumor, that will weaken the bone in addition to chemotherapy that's going to be weakening these structures as well. So just remember that picture and you'll remember some of the important things there. So osteoporosis, by definition, it is a Z-score on a DEXA scan below -2.5. And a lot of times we will supplement patients with vitamin D and calcium to start. And if that doesn't turn around that score, then they need to be on bisphosphonates or other types of medication that will help to essentially reduce the osteoclastic activity and promote the osteoblastic activity. Because a lot of people forget that bone is not just a solid block. There's constant remodeling and turnover. So there's different cells that will break down bone, and there's different cells that will fortify that bone. And of course, with patients that are osteoporotic, there's an imbalance in the negative there. And we encourage patients to really follow up with rheumatology or endocrinology to manage these medications for them. So how do we make a diagnosis? Well, patients could have pain for many different reasons in their back, right? But we see a lot of times that almost like the shopping cart syndrome that we were discussing before in the mile procedure, we sort of see that posture as well with patients. They tend to be a little bit more frail appearing, a little bit skinnier, and will have just kind of that hunched over appearance all the time, regardless of whether they're walking or not. So we'll see that exaggerated thoracic kyphosis. When we do the physical examination, one thing that we like to do is percuss or lightly tap the spinous processes that we believe corresponding to the levels of pain. So when we percuss, for instance, the spinous process here, it's going to send a vibratory force all the way to this vertebra here. This is not the fractured one, but this is up here. And you can really see the difference between this nice boxy appearance on MRI versus this, where that superior end plate is kind of caved in and darker. You could obviously make out a bigger difference here with the bone marrow edema seen on the T2 weighted image of the MRI, and that scooping of that vertebral end plate, and you can really see it here on that STIR imaging. So kind of leads me to the next point, that imaging is everything. If you suspect it, image it. And the best imaging that you could get typically is an MRI or even a nuclear medicine bone scan if that MRI is negative and you think that they do have a fracture. I have diagnosed probably at least 10 to 20 compression fractures that three of these phases on the MRI were negative, but the bone scan was positive, showing that there was some sort of nuclear turnover. So how do we treat it? Well, conservatively, we'll start with relative rest, which I don't really know what that means. I think it's just people try not to do much of anything, but ultimately you're still going to have to get up, you're going to have to go to the bathroom, you're going to have to make food, you're going to have to eat, you're going to have to be somewhat functional, but all that can be extremely painful for patients suffering from a compression fracture as well. We really promote the no flexion model here. I'll go back a slide here. As you can see, if you put more of a flexion force, this is actually going to become worse and more weight is going to be placed on the compressed segment. So we try to promote an extension or a neutral base position for these patients. And if they can't do it on their own, or it's just really that painful and constant, we put them in a back brace. So basically, this is a good example of an LSO or a lumbosacral orthosis. And this is a good and uncomfortable example of a TLSO, which extends into the thoracic spine. They make them also where there's shoulder straps as opposed to the sort of T-strutted device here, which especially for women is super uncomfortable, but it definitely helps to not allow for patients to go into that flexion position. The reason why we decide to do a TLSO versus an LSO is typically if it's a higher level lumbar fracture or a thoracic fracture, then we're putting them into something like this or a device like that with the shoulder straps. So, two different things that we can do within the realm of vertebral augmentation. One is a kyphoplasty and the other one is a vertebroplasty. The difference being is with a vertebroplasty, which was first performed in 1984 in France, this is pretty much just putting in some high-grade cement into the vertebra. You're not really changing the structure of that vertebra, you're just filling in the cracks, so to speak. When we do a kyphoplasty, we are actually augmenting or changing the structure of that vertebrae prior to injecting in cement. You can do this in a variety of ways. You don't have to just use the typical balloon. You could use it with a curette, which is sort of a sickle-shaped metallic instrument that's used to further create a cavity. You can use a lot of other non-balloon technologies that within the last few years have come out as well. So, now another show of hands. How many people still own a pair of pants like this? It's in their closet. So, we call it hammer time because for those of you who are aware of the procedure, we use a hammer or we use a mallet to drive the needle in. So I figured this was to add some brevity to the talk. So how do we do it? Well, essentially, we are trying to, or at least we're starting from here, and we're trying to get into here with the instrumentation and fill that up. So we're using that hammer to essentially drive the needle forward into that anterior portion of the vertebrae, the vertebral body. And once we're there, we will either put a balloon or the other devices I mentioned to create that cavity and increase the height, in this instance with the balloon. Then we're putting in the cement, and then we're allowing that cement to sit and dry, and that's pretty much the procedure. Sounds very simple, sometimes it's not. So who does this? Well, obviously, since we're here for pain management physicians do it, and within that we have the specialties, I should say, of physiatry / PM&R and anesthesia, who make up the majority of patients who do these. There's also neurologists and internal medicine doctors and even some psychiatrists, believe it or not, that wind up doing pain management fellowships that do these procedures. And then, of course, IR and ortho will sometimes get their feet wet and do these. In a hospital setting, if the patient winds up having a kyphoplasty in the hospital, chances are they're doing it with IR. Very often, though, we will see these patients weeks or months after they've actually had their fracture. And to me, that's horrible, but that's the circumstance that we're in. Very often, we'll be the first ones to actually diagnose the fracture. scary, right? They went to a hospital or they had imaging, and either the fracture was completely missed by a radiologist, or it just wasn't dealt with. They saw somebody in the hospital and said, oh, we'll just give you some pain medications and a brace, and you just go home and rest up and you'll be good in a few weeks. Take care, see you later. That's not really the case. We rarely see that, especially in a population where patients may have already had chronic pain with that. So that's very important that the fracture is actually seen, that we do get the imaging, and that it's dealt with very quickly. So, like I mentioned, the hospital will be very quick to discharge the patients. A lot of time, to be honest with you, it's money driven, because it won't be worth them to do a kyphoplasty at that point in time for the hospital. So they'll probably make more money off the back brace that they'll give and just send the patient home and get them out of their hospital. Like I mentioned, it's not an expeditious referral a lot of times to get to us where we can finally do something about it. I saw a patient who had a fracture, I think in May of 2022. I saw her for the first time in August. Got to looking at the imaging the next time she came in, and she had a fracture that was untreated, that still had edema in it, which means that it's still breaking currently, it's not healed. And it took us, I think, until, I want to say October or November to actually do the kyphoplasty. So do the math on that. It took about 6 months just for her to actually get a procedure like this. And once we did it, she felt great. But could you imagine living for 6 months with that type of pain? It's ridiculous. So I think just as, being somewhat of a representative for healthcare at this point, I think we need to just be very expeditious on all this, and really understand and educate those who are involved in patient care to be aware of this. So how do we actually get pain relief when we do this kyphoplasty? How does putting cement in a vertebral body actually help reduce pain? It's an interesting question with a relatively complex answer. But other than just filling in the cracks and adding that sort of stability to it, there are nerves that supply the vertebral body with its sensation. So for instance, the basovertebral nerve that we're seeing a lot of talk about in regards to the intricep procedure, it's the same nerve that's being affected. And what we see is that this nerve will supply the superior and inferior end plates. And a lot of times within this vertebroplasty or kyphoplasty situation that we're doing, the cement, there'll be an exothermic reaction, meaning that it's heating up. And within that could heat up the nerve fibers and essentially ablate them and kind of get rid of their pain sensing abilities as well. So that's helping with the pain, and of course, with the structural stability of all those little microfractures not moving around and creating inflammation, it'll help in that way as well. And one of the biggest things that I think is overlooked a lot of times with this whole do a kyphoplasty or don't do a kyphoplasty type discussion is, does it really help to reduce morbidity and mortality? And it absolutely does, because patients, if they're in that much pain, they're not going to be moving. They're not going to be getting up. They're not going to be participating in weight-bearing exercises. And that's going to be a domino effect, which we're going to talk about a little bit later. So here is an actual case that we did, I think maybe 3 or 4 weeks ago. So the view that we're looking at here is a straight AP view. It's a dead-on view, and the view over here is a side view. So we see here, it's a little bit hard to make out, but we see this circular pedicle here and here. This one, I think we could all agree, looks a lot better and easily seen compared to this side. So I decided to enter on this side here. And we are basically angling down, going towards the center of that vertebral body as we do it. And from here, this is the posterior aspect, and we're trying to angle this right down into the center/anterior portion of the vertebral body. On the next slide, you'll see the progress there, how we got it pretty much to the middle or 60% in, and we got this right to the midline. We added a drill to create a little bit of ease for the rest of the instrumentation to go in. And then you could see that we placed a curette to get pretty close to the anterior border of that vertebral body. And then we put the cement in. And kind of, I'll go back here for a second. It's hard to make out on this image, especially on the screen here, but there is a little break in the bone right around here, and you'll see that the cement goes right through that, and it basically fills in the crack. Very small part of it goes into the adjacent disc space, and it's important because we filled in that crack, and that could have led to even more instability in the future. But you see that that superior end plate is very much filled in where it needs to be on this view as well as on this view. And this is without the instrumentation. Procedure took about 15 minutes to do. It's very quick if you get the good anatomy and you're able to get everything structurally in place. So take a look at this. No instrumentation, just a little bit of cement. And take a look at the alternative. Which one would you rather have? Well, surprisingly enough, a lot of times the insurance company would rather have this option. I don't know why, but essentially they look at this from saying that there's occasionally a lack of evidence for doing kyphoplasty or vertebroplasty in certain situations, but they will gladly pay for a 6-level fusion that will absolutely create more issues for the patient in the future. It will also cost probably between 10 and 50 times as much just in the actual procedure itself, the hospital stay, the follow-up visits, the therapy, everything like that. Whereas 20 minutes later after this procedure, you're basically done. So we'll get into that a little bit more. We can perform these procedures outpatient 99% of the time. The only reason why we wouldn't, it's either a very risky, kind of neurologically compromising procedure in certain instances, or the patient just has a lot of comorbidities and they need to be in a hospital-based setting for the anesthesia purposes. So I categorize these into acute, subacute, and chronic phasicity. So within the first 4 to 6 weeks, we usually call it acute. If it's 6 weeks to kind of an arbitrary amount of time, whether it's months or years after, that would be subacute. And then chronic is when it's just beyond the point and the fracture is technically healed without intervention. And a lot of times this subacute stage will persist for a very long time because that deals with having edema and continued fracturing without healing within the bone itself. And I'll be honest, a lot of the patients that we wind up seeing that I do vertebral augmentation on are in this phase about 90% of the time because it takes them such a long time to actually get to us. And even in the patient that I described that 6 months later we were doing the kyphoplasty on, she still had that edema within the bone there and continued fracturing. So how do we prepare? Well, of course, like I mentioned, imaging is super important. In certain patients that are on blood thinners or have a high tendency for infection, we're definitely getting labs on them. We want to look at their medications, make sure that they're not on any blood thinners. Again, just kind of confirm whether they're not on any sort of biologic medications or medications that we need to monitor certain parameters on. Cardiac clearance, anesthesia assessment is also important in majority of patients. So, like I mentioned, procedure does not take long at all to perform. We do not need to cut anything open. If anything, just to allow the relatively thick needle to get in there, I will make a small little stab incision with an 11 blade. We don't even suture it. We just put a steri strip over it, and within 3 to 7 days, it's 90% healed. And then, as I mentioned, it takes about 20 minutes, give or take, on the specific cement that we're using for the fracture to fully dry. So adverse events, these top 3 can occur in any sort of injection. Even if you're getting a COVID booster, you could get all these things. When we're doing kyphoplasties, we do have a few more risks that are super pertinent and can occur, and I've seen occur. Luckily not with my own patients, but with others. You do not want to get a pneumothorax with an 11 gauge needle. You don't want to put air into the colon, and you certainly don't want to put cement into the lungs either. So 20 minutes in the supine position after the procedure is done is more than enough time for the cement to dry. You're going to keep that dressing on for 48 hours. Then I'll remove it, and we'll keep the steri strip on for another week or 2 until it falls off typically. Ice for post-procedural pain, 20 minutes on, 20 minutes off is the status quo on that. And usually I tell patients for about 95% of anticoagulants, they can start them beyond 24 hours from the end of the procedure time. And then I'll usually like to have patients come back into the office a few days later just to check the wound, just to make sure everything is healing as we thought it would. So aftercare, physical therapy is super important. We want to make sure that patients have the structural support to their spine to where they're going to have good posture, good stability. They might need to learn to walk again in a better fashion, to where they're not leaning forward, to where they're more upright, to where they have that strength, flexibility, support of the spine. As I mentioned before, weight-bearing exercise, that's super important for patients that have osteoporosis. If there's non-weight-bearing exercises, it is not helping with osteoporosis. You need gravity and you need actual weight-bearing to make a difference with these patients. And we talked about specific treatments for osteoporosis in a previous slide. So if these patients have to wait long enough to have a kyphoplasty and they're still in pain, most of the time that kyphoplasty will not give them 100% pain relief. By that time, other mechanisms will have occurred within the spine that will essentially place more of an impact on other regions and will create other issues. So for example, a lot of times patients will have 2 different types of pain and will not even know it. So we'll treat the kyphoplasty, they'll do great with that type of pain, but they'll say, oh, whenever I stand up, whenever I kind of have to lean back, I have pain. And we say, well, that's not due to the compression fracture because we treated that, and that's more in the front portion of the spine. This might be related to the facet joints or something more in the posterior aspect of the spine. So what we'll do is we'll do some diagnostic medial branch blocks or some facet joint injections right into the joint, and they'll get better. And we'll say, all right, well, in the interim, you have basically developed some facet arthropathy and some pain related to that. And what's good about that, at least with us being interventional and pain management physicians, we could do the subsequent radio frequency ablation, which typically helps tremendously with the residual pain that they're having. So I think this is my last slide coming up here. It's really a domino effect if we don't treat these patients expeditiously. So just like one domino falls, the next one will fall. And I've seen it so many times where patients will just delay on their treatment, whether it's due to them or due to just the system in general, and they'll have, let's say, a T12 compression fracture. We might even treat their compression fracture and we'll see them for follow-up, and within that time, because we waited so long on that, they'll have a T11 compression fracture or an L1 compression fracture or a T7 compression fracture because that was already in the works and already brewing because we did not treat them quick enough. So it's a problem. So again, as I alluded to before, you don't want these patients to have any further structural instability or functional decline, because it's going to lead to all these other things that are going to decrease their ability to live a normal and happy life. So just included some references here. I had to self-reference here, unfortunately, to prove a couple points. But here's some contact info for me and for the practice. And I want to thank everybody for your time. And I'm happy to be here. Thank you.